In the last few sketches, we covered pathologies that affected everything from the gallbladder to the liver to the bile ducts themselves. But you can't really spell hepatopancreatobiliary system without the pancreato. In the next two sketches, we'll cover the hugely important pancreatic system and just how much can go wrong when it takes a day off. Let's say your pancreas is shirking its usual bicarbonate, trypsinogen, and insulin duties, and instead is enjoying some slow-roasted pork at a beach luau. Acute pancreatitis is a serious, sometimes life-threatening disease with a mortality ranging from 10 to 30% depending on the severity and etiology. And what happens when something acute happens over and over? It becomes chronic, of course. In this sketch, we'll discuss the causes, symptoms, and complications of both acute and chronic disease. And just like the antics here on the island, it's all fun and games until someone gets hurt. Or, gets pancreatitis. We'll start with the acute variety. The main pancreatic enzyme involved in acute pancreatitis is trypsin, the active form of the zymogen trypsinogen. Normally, trypsinogen is activated to trypsin by the enzyme enterokinase, also known as entropeptidase, in the lumen of the small intestine. Once activated, trypsin cleaves peptide bonds in both dietary proteins and in other zymogens secreted by the pancreas, resulting in their activation. So, trypsin is a protease, cutting up proteins, just like our recurring protease meat cleaver. Let's get this luau started. Trypsin even cleaves and activates trypsinogen. Thus, trypsin is a key enzyme responsible for the activation of many proenzymes, including its own. This is relevant because, regardless of the underlying cause, pancreatitis always results from premature or inappropriate activation of trypsinogen to trypsin. So keep your eye on that meat cleaver. Toxic injury to the pancreas or obstruction of the pancreatic ducts can result in premature activation of trypsinogen inside the pancreatic acinar cells, which sets off a cascade of activation of all the different enzymes produced by the pancreas. So instead of a cleaver, it's like one of those automatic handheld meat-cutting devices, accidentally turned on inside the pancreas and just trypsinizing proteins left and right. This, in turn, leads to a vicious cycle of autodigestion and inflammation inside the pancreas. Yeah, that's right, my friends. It's time for the main course. Roasted pig. See that roaring fire? It emphasizes all the inflammation that's going on in the pancreas. One specific pancreatic enzyme that gets released, lipase, is responsible for the digestion of adipose tissue and fat necrosis. At Sketchy, the enzymatic breakdown of lipids is always depicted as a lipid-laden pig roasting over a fire. You know what I'm talking about. All those fatty juices dripping down. Did you know pancreatitis was going to be so savory? This leads to the formation of fatty acids that bind to calcium ions, resulting in precipitation of insoluble calcium salts. Just think of these drips of roasted fat collecting on the calcified pile of bones from last week's luau. These calcium precipitations themselves induce even more inflammation, further exacerbating the problem. So overall, in the setting of pancreatitis, both fat necrosis and calcium deposits may be visible on histology. This whole process can occur either acutely or chronically. Acute pancreatitis involves an acute inflammatory response to some kind of pancreatic injury. This usually won't progress. Chronic pancreatitis, on the other hand, involves ongoing inflammation leading to progressive, permanent structural damage and, eventually, irreversible exocrine and endocrine impairment. Let's start with acute. It turns out that gallstones are the most common cause of acute pancreatitis, accounting for 35 to 40% of cases. Just one little gallstone. Plop. It's all it takes. If a stone gets pooped out of the gallbladder and works its way into the common bile duct, it can obstruct all those pancreatic secretions that are trying to squirt into the duodenum. It can even cause the reflux of bile into the pancreatic duct. Now, all you sketchy veterans out there know whenever I say gallstones, what I really mean is sea gallstones. Classic. And in this scene, the common bile duct is depicted by that common trunk of seaweed, joining together the duct from the gallbladder and our pancreatic sea sponge. See how it's obstructed by all those sea gallstones? Not good. It doesn't have to be just gallstones, by the way. Biliary sludge, pancreatic masses, and duodenal strictures can also cause obstruction of the common bile duct and lead to pancreatitis. The second most common cause of acute pancreatitis is chronic alcohol abuse. While alcohol can be directly toxic to the pancreas, it also increases the thickness of pancreatic secretions. These viscous secretions can plug up the plumbing within the pancreas and obstruct the smaller ductules, leading to inflammation, enzyme activation, and you know the drill, pancreatitis. I mean, just look at this guy in charge of chopping the meats, ignoring his duties as he indulges in a little okalehao. Get it together, man. There's kids around. At least put the safety on that thing first, or something. All right, besides the big two, there are a few other causes of acute pancreatitis you should remember. How about hypertriglyceridemia? And I mean extreme hypertriglyceridemia. Though the pathogenesis is unclear, it may have something to do with pancreatic lipase metabolizing excess triglycerides in the blood into free fatty acids. These free fatty acids, if you recall, can have toxic and inflammatory effects on the pancreas. At Sketchy, triglycerides are represented by tridents. So for hypertriglyceridemia, just think of a trident raised high in the air, just like this fork wielded by our first gluttonous tourist. Remember, we're talking extremely high triglyceride levels here, somewhere greater than 1,000 milligrams per deciliter. Okay, he needs to calm down. When you see triglyceride levels that high, you should think of the familial hyperlipidemia syndromes. Specifically, type 1, which has high chylomicrons, type 4, which has high VLDL, and type 5, which has high chylomicrons and VLDL. Like father, like son. Other secondary causes of hypertriglyceridemia with the potential to cause pancreatitis include diabetes, alcohol, and pregnancy. Numerous medications are associated with pancreatitis as well. Some cause immunologic reactions, some have a direct toxic effect, and some increase the viscosity of pancreatic juices. In this scene, we've included a recurring symbol for adverse drug effects, a mortar and pestle, this time being used to dole out some tangy barbecue sauce. Pass the drug-induced pancreatitis, please. Finally, trauma to the pancreas can make it angry and result in pancreatitis. In fact, seatbelt trauma is the most common cause of pancreatitis in children. At Sketchy, trauma is represented by an arm cast, and this time we've even made the sling look just like a seatbelt. Trauma can also be iatrogenic, as is the case with ERCP, or endoscopic retrograde cholangiopancreatography. This is an endoscopic procedure that involves sticking a tiny catheter through the ampulla of Vater and right into the common bile duct in order to inject contrast dye for imaging. Instruments can also be inserted into the ampulla to remove gallstones or open up strictures. Any part of this procedure can damage the pancreas and cause acute pancreatitis. In this scene, instead of an endoscope, think of a periscope, scoping out that pancreas. Acute pancreatitis is one of those disease processes that's diagnosed almost exclusively by the history and physical, with minimal laboratory or radiological testing required. Typically, patients present with severe, sharp, epigastric abdominal pain. And I don't know how you limbo, but if there isn't at least a moderate risk of someone ending up with a penetrating abdominal wound, you're doing it wrong. Oh, looks like chubby Checker over here couldn't quite make it under. Ooh, right in that epigastric area. Ugh, looks like he strained his back too. Fitting, really, because in the setting of acute pancreatitis, the pain often radiates to the back due to the retroperitoneal location of the pancreas. Nausea and vomiting are almost always present. That's what you get for sampling the pig meat too early. Patients may also have systemic findings such as fever, leukocytosis, and elevated inflammatory markers. And after hours of standing at the rotisserie, cranking away, that'd be a bit feverish as well. The two most common lab values associated with pancreatitis are amylase and lipase. They can be found in the serum because the inflammation of pancreatitis causes these enzymes to leak into the bloodstream. For amylase, we need to show some sugars breaking down. How about this sugary apple getting roasted along with the pig? Amylase is less specific for pancreatitis, however, because it's also produced by the salivary glands. Hence the whole apple in the pig's mouth tradition. It's purely aesthetic, by the way. Lipase, we already discussed. It's embodied by that dripping lipolysis juice. Succulent, to say the least. Elevated lipase is more specific for pancreatitis, so look for this to confirm your clinical diagnosis. In severe pancreatitis, hypocalcemia may be seen due to all the digested free fatty acids binding to calcium. Calcium levels may even drop enough to cause symptoms such as tetany, a poor prognostic sign. Bloop. Down goes that calcium ice cream. The massive inflammation produced by severe acute pancreatitis can also cause hypovolemia due to accumulation of fluid around the pancreas. Let this tide marker measuring low tide remind you of the volume that's receded out of your vasculature and into the interstitium. This third spacing of fluid into the abdomen can even cause hypovolemic shock. And before we move on, there are a few more clues in the lab findings that can help you zero in on the cause of pancreatitis. If there's suspicion for gallstone pancreatitis, abdominal ultrasound can be performed to confirm the presence of gallstones. Serum transaminases are also helpful for confirming the origin, especially if the patient has little to no alcohol history. If a gallstone is lodged in that common bile duct, bile backs up and damages the liver too. So the liver enzymes AST and ALT are released into the serum, usually more ALT than AST. To help you remember to look for liver enzymes in the setting of gallstone pancreatitis, especially ALT, we've drawn in another seagull here, making off with the container of sea salt rib roast seasoning. See how ALT is highlighted over AST? Patients with alcohol-induced pancreatitis will conversely have consistent lab findings with alcoholism. This includes an AST to ALT ratio of greater than 2:1. A toast to elevated AST. Alcoholic patients may also have macrocytosis, measured on CBC as an MCV of greater than 100. Yup, big red blood cells, just like the big red flowers on that overtly touristy Hawaiian shirt. Sometimes you'll even be able to measure an acutely elevated serum alcohol level. Don't worry, we'll go over AST and ALT in much more detail in our liver enzyme sketch. A common complication of acute pancreatitis is the formation of a pancreatic pseudocyst. Remember, autodigestion of the pancreas causes large amounts of pancreatic secretions, chock full of digestive enzymes, to be released. The presence of these secretions produces an intense inflammatory reaction, leading to a liquefied mess of necrotic fat. Eventually, the liquefied pancreatic tissue is walled off by a capsule of fibrous granulation tissue. Yup, just like the liquefied core of these fibrous coconuts. Pseudocysts on me, everyone. Wait, why is it called a pseudocyst? Technically, the walls are not made of true epithelium, which would make it a true cyst. Instead, there's a layer of granulation tissue, rife with fibroblasts and neovasculature. Pseudocysts usually spontaneously resolve, but watch out. They can become secondarily infected or even leak into adjacent tissues. Sometimes in severe pancreatitis, blood flow to the acinar cells is compromised, which causes further autodigestion and progression of the disease to acute necrotizing pancreatitis. This is a bad sign, as you can probably tell from the ominous necrotic tiki statue over here. The necrosis can extend beyond the pancreas itself and spread to the surrounding retroperitoneal fat, omentum, or mesentery. Macroscopically, this will show up as white, chalky areas of fat necrosis, represented here by the chalky white-colored skulls across the tiki statue's abdomen. Acute necrotizing pancreatitis causes hemorrhage as well, and on gross pathology, you'll see red-black hemorrhagic areas. Extensive necrosis can even lead to diffuse hemorrhage within the pancreas, a poor prognostic indicator that carries a 20% risk of mortality. Infection with gut bacteria is also very likely in acute necrotizing pancreatitis, often leading to septic shock. It's just badness all around. While we're on the topic of mortality, one of the worst complications of pancreatitis is the development of acute respiratory distress syndrome, or ARDS. Wait, pancreatitis leading to lung damage? What the Kyoki o Niuhai? Yep, autodigestion of the pancreas results in the release of phospholipase into the bloodstream, which then travels to the lungs and breaks down surfactant. Massive pulmonary edema ensues. On imaging, you'll see diffuse bilateral opacities completely white out the lungs. Hence our recurring sketchy symbol, the great white ARDS shark. this time prowling the waters off the Hawaiian coast. Finally, one last important complication of pancreatitis is splenic vein thrombosis. See that jellyfish that's washed up on shore? Kinda spleen-shaped? With tendrils that evoke an image of the splenic artery and vein? Well, these vessels run right behind the pancreas. And inflammation in the overlying organ can cause blood clots to form in the splenic vein, as depicted by the thrombotic, fibrous skirt worn by the hula girl stepping on that splenic sea jelly. Splenic vein thrombosis causes pressure to back up into the gastric veins, leading to gastric varices. Watch out, because when those varices rupture, your patient will come in with hematemesis and dark stools, sure signs of an upper GI bleed. So how is acute pancreatitis treated? Essentially, there's not much we can do. Treatment for most cases revolves around preventing further release of pancreatic enzymes by keeping the patient from eating for a couple of days, IV fluid and nutrition replacement, pain control, and antibiotics if a concomitant infection is suspected. Once the acute phase is over, the next step is to treat the underlying cause of the pancreatitis. This can mean cholecystectomy for gallstone pancreatitis, alcohol cessation counseling for alcohol pancreatitis, or fibrates for familial hypertriglyceridemia. Long-term or recurring insults to the pancreas inevitably lead to irreversible damage to the pancreas, the hallmark of chronic pancreatitis. The most common known cause of chronic pancreatitis is chronic alcohol abuse. And you know how tourists get. Chronically drunk when they should be taking in the scenery and rich culture of Hawaii. Mea he mea hila hila. It looks like a few of his friends are certainly enjoying themselves, though. Idiot. It's just a well-thought-out gag full of sophisticated humor. Let that idiot sign on his back remind you that many cases of chronic pancreatitis are, in fact, idiopathic. In other words, we have no idea what's causing it. Another important cause of chronic pancreatitis to know is cystic fibrosis. In CF, thickened pancreatic secretions, similar to those of chronic alcoholism, cause obstruction, inflammation, and eventually lead to chronic pancreatitis. Check out our CF video for everything you need to know about cystic fibrosis. The main theme in chronic pancreatitis is parenchymal fibrosis, leading to chronic duct obstruction and long-term inflammation. Eventually, the pancreas can't take any more of this and starts to atrophy and calcify, as depicted by the sea sponge that's washed ashore, dried out, atrophic, and I definitely see some fibrosis there, just in bad shape overall. Calcified concretions can be seen throughout, as depicted by the calcific white flowers that adorn his Hawaiian shirt. A very helpful clue for diagnosing chronic pancreatitis is the visualization of calcifications within the pancreas on CT or ultrasound. Just like in acute pancreatitis, a pseudocyst may be found on imaging as well. So let's draw in our symbol for pseudocyst, a fibrotic coconut capsule surrounding a liquefied, juicy core. Sounds refreshing, right? Over time, pancreatic acini are lost, resulting in some major exocrine dysfunction. Without any lipase in the GI tract, for example, patients develop steatorrhea, or bulky, frothy stools due to the high fat content. Yeah, that's not just seafoam in the water there. Patients will also have weight loss and deficiencies of the fat-soluble vitamins A, D, E, and K. See that dilapidated dock in the back? Yep, it's our recurring ADEC dock, emphasizing the GI loss of the corresponding fat-soluble vitamins. Eventually, chronic pancreatitis ends up destroying islets of Langerhans as well, which means say goodbye to endocrine function. This can manifest as insulin-dependent diabetes. So above our trash tourist here, we've drawn in some elevated candy lanterns in order to highlight the chronically elevated blood glucose seen in the setting of diminished pancreatic insulin production. Unlike acute pancreatitis, amylase and lipase don't really give us much useful information when it comes to chronic pancreatitis. In end-stage disease especially, loss of exocrine and endocrine function means that you will not find an appreciable amount of pancreatic enzymes in the serum. Therefore, diagnosis of chronic pancreatitis is made almost exclusively by the patient's history. One last thing to note. All that chronic inflammation in the pancreas increases the risk for pancreatic adenocarcinoma. So watch out for those cancer crabs. That's for the next sketch, however. So let's bring this luau to a close, shall we? To recap, pancreatitis comes in two flavors, acute and chronic. Acute pancreatitis is most likely going to be caused by a gallstone blocking the ampulla of Vater and causing autoactivation of trypsin. Like an automated meat cleaver, it starts hacking away, leading to abdominal pain, nausea, vomiting, some sizzling fat necrosis, maybe some hypocalcemia, and hypovolemia if the tide is right. This liquefied mess of necrotic fat is eventually walled off by a capsule of fibrous granulation tissue, as evoked by that fibrous coconut beverage. Phospholipases can also travel up to the lungs to cause ARDS. Whoa. Don't forget about the revelers either. If alcohol is the cause of pancreatitis, expect an AST to ALT ratio greater than 2:1. A toast to elevated AST. Speaking of alcohol, it's the #1 cause of chronic pancreatitis, marked by diffuse parenchymal loss and fibrosis and calcification, and eventual pancreatic burnout, just like that sad, shriveled sea sponge in the back there. Expect a lot of the same complications in chronic pancreatitis, compared to acute. The big thing to remember with chronic, however, is loss of exocrine and endocrine function, leading to malabsorption, weight loss, and even diabetes. Chronic pancreatitis can even be a risk factor for pancreatic adenocarcinoma. So keep the sunscreen handy, because we're headed to the next island over, where we'll meet a ragtag group of castaways who embody all that is pancreatic cancer.